Hey everyone, and welcome to this explainer. Today, we're unpacking a condition that operates kind of like a silent, progressive ticking clock inside the human eye. We're talking about diabetic retinopathy. Now, if you or someone you love has diabetes, you already know it affects the entire body. But today, we're going to zoom right into the back of the eye, into the retina. We're going to trace this journey where the eye's incredibly delicate plumbing system slowly, eventually breaks down under the relentless stress of diabetes. Okay, let's dive right into this, and let's immediately anchor the stakes here. 90%. Let that sink in for a second. That is an absolutely staggering statistic. Roughly 90% of patients develop diabetic retinopathy after 30 years of living with the disease. And when it comes to this condition, the absolute most important risk factor isn't actually just how well you control your blood sugar, though don't get me wrong, that is incredibly vital. It's time. The duration of the diabetes is the ultimate ticking clock. So, here is our roadmap for today. We'll start with the diabetic eye threat, look at how the early retinal damage begins, move through the non-proliferative and proliferative stages, and then finally wrap up with screening and medical treatments.
All right, Section 1, the diabetic eye threat.
And moving right along to Section 2, how retinal damage begins. Let's take a microscopic view. To really grasp why this is the leading cause of blindness in Western countries, we've got to ground ourselves in the core science first. Basically, diabetic retinopathy is fundamentally a microangiopathy. What does that mean? Well, it's a disease of the exceptionally fine blood vessels, specifically the retinal precapillary arterioles, the capillaries, and the venules. Honestly, just think of it as a microscopic plumbing failure. These tiny biological pipes that supply oxygen and nutrients to your retina are physically breaking down as a direct consequence of long-term metabolic stress on the body. Now, this breakdown triggers a pretty devastating chain reaction. It starts with the capillary basement membrane thickening and the loss of these essential structural cells called pericytes. This early damage leads to microvascular occlusion. Essentially, the tiny pipes get clogged up, and when blood can't flow, the retina becomes ischemic. It is literally starving for oxygen. In a desperate response, the remaining capillaries get weak and they form microaneurysms. This creates this disastrous leaky pipe scenario where fluids, proteins, and even blood escape directly into the delicate tissues of the eye, causing retinal edema. Okay, Section 3, non-proliferative retinopathy stages, or NPDR for short. This is the point where that microscopic damage actually becomes visible to an eye doctor. They start seeing the very first signs of those leaky pipes. We're talking microaneurysms, deep dot and blot hemorrhages where blood has essentially pooled, and these yellowish, waxy-looking patches called hard exudates. Actually, those are just leaked lipid deposits clumping together right there in the retina. But as that clock keeps ticking, the ocular environment deteriorates further, bringing us to a really critical diagnostic threshold. Doctors use a very strict 4-2-1 rule to diagnose severe NPDR. Listen, if a patient hits any one of these criteria, the warning sirens should absolutely be going off. They're looking for severe microaneurysms or hemorrhages in all 4 quadrants of the eye, or maybe abnormal looping and dilation, called venous beading, in 2 quadrants, or intraretinal microvascular abnormalities. That's basically just abnormal branching of vessels, and they look for that in 1 quadrant. If any of these are present, that eye is dangerously close to the next, much more destructive phase.
Which brings us to Section 4, proliferative retinopathy and maculopathy. This is the severe climax of the disease, and it develops in over 50% of cases after about 25 years.
So the crucial point here, the big dividing line between these 2 main stages, is blood vessel growth. In the non-proliferative stages we just talked about, we have leaks and blockages, right? But the original vessel structure is still mostly intact. But in proliferative retinopathy, or PDR, the oxygen-starved retina absolutely panics. It starts releasing chemical signals to grow brand new blood vessels. This is called neovascularization, and it is the absolute hallmark of PDR. The problem, these new vessels are chaotic, they're abnormally fragile, and they grow in all the wrong places. They can easily rupture and bleed massively into the vitreous gel of the eye, or even worse, create fibrous scar tissue that can literally pull the retina right off the back of the eye. And alongside these progressive stages, patients are also facing a direct threat to their central detailed vision. This is known as diabetic maculopathy. As capillary permeability increases, fluid just builds up in the macula, and it becomes a really urgent crisis when it develops into clinically significant macular edema, or CSME. This happens when retinal thickening or those waxy hard exudates appear dangerously close. We're talking within just 500 microns to the very center of the fovea. If this isn't treated quickly, the patient's ability to read, to drive, or even recognize faces, it can be permanently lost.
Let's move to Section 5, Screening and Medical Treatments. Let's look at how we actually step in and halt vision loss.
And this brilliantly illustrates our first major intervention, focal laser treatment. If a patient has dangerous macular edema, doctors will use a highly precise argon laser. They essentially apply tiny, hyper-focused burns to specifically target and seal off those individual leaking microaneurysms that are sitting somewhere between 500 and 3,000 microns from the macula center. Think of it like a microscopic spot weld. It physically welds the leaks shut to preserve that crucial central vision.
Let's move on and see how this builds, because when the swelling is more widespread, surgeons have to escalate to grid laser treatment. So instead of targeting individual microaneurysms, the surgeon applies a grid pattern of tiny laser burns all across the macular area. This is specifically used to combat diffuse diabetic macular edema. It effectively alters the cellular environment to help the retina pump that excess fluid away, bringing down the widespread swelling. But what if the patient has already advanced into that severe proliferative stage with the dangerous new vessel growth? Well, the solution here is intense and honestly a little bit medically ironic. It's called pan-retinal photocoagulation, or scatter laser treatment. The surgeon applies an astounding 1,200 to 1,600 laser spots across the peripheral retina. And the goal here is actually intentionally destructive. They are purposefully destroying the peripheral ischemic retina. Why on earth would they do that? Because that starving tissue is exactly what's sending out those panic signals, causing the dangerous neovascularization. By sacrificing the peripheral tissue, they completely remove the trigger. This forces those fragile, bleeding new vessels to regress, ultimately saving the eye from total blindness.
Now, beyond lasers, the modern treatment arsenal has expanded significantly. But first and foremost, you've got to remember that none of the surgical treatments work long-term without strict metabolic control of blood sugar and lipids. That's baseline. Pharmacologically, we now use these incredible targeted injections right into the vitreous of the eye, like the steroid triamcinolone or VEGF inhibitors, to chemically stop the swelling and stop that vessel growth. And in the absolute most advanced cases where fibrous bands have formed or massive bleeding has already occurred, surgeons can perform a complex pars plana vitrectomy. They literally go in, clear out the blood, and physically repair a tractional retinal detachment. These treatments are amazing, but they only work if the disease is caught in time. And that brings us to the most actionable takeaway of this entire explainer, the screening timeline. Because the early stages have literally no symptoms, proactive screening is your only defense. If you have diabetes but no retinopathy or just mild signs, you need an exam yearly. If it hits the moderate stage, that window shrinks to every 6 months. Severe NPDR requires a check every 3 months. And if you cross that line into the early proliferative stages, you've got to be screened every 2 months. So we've seen how the delicate pipes of the eye slowly break down, and we've seen the incredible lasers and surgeries used to fight back. But it all comes full circle to this final thought. 90% of people will develop this after 30 years of diabetes. It is a ticking clock, for sure, but it's one you can actually monitor and manage. So I'll leave you with this. Knowing what's happening invisibly at the back of the eye, when was the last time you or your loved ones with diabetes had your eyes comprehensively checked? Because knowledge is power, absolutely, but taking action is what actually saves your sight. Thanks so much for joining me for this explainer.